So please start in 3.
Very good evening to all who have joined us here. Myself, Dr. Vinod Kalkoti from Medical Affairs team. On behalf of Zenith Division of Intas Pharmaceutical, I welcome you all for this edition of Nephro Live 2025. The main agendas of today's show is to review the current therapeutic approach to chronic kidney disease, mineral bone disorders. As always, to chair this session, it's my pleasure to introduce Dr. Dinesh Kolar, sir. Who is currently the chairman and head of nephrology and renal transplant medicine at Max Super Specialty Hospital in New Delhi. He has, in fact, more than 120 research publications in several reputed index national and international journals to his credit. He is also the peer reviewer of several prestigious journals and national lead investigator in several multinational trials like DAPA CKD, BAX, Duo, Arctic, Pacific, and Zenith trial till date. Dr. Kullar is also the postgraduate teacher for more than 25 years. He is also the founder, program director of DM Nephrology in Nepal and a teacher coordinator of DNB Nephrology and NB assessor for DNB program in nephrology. He is in fact involved in more than 5,000 successful renal transplant, including large number of ABO incompatible and highly sensitive recipients till date. He is also the former president of Delhi Nephrology Society in 2023, executive council member of ISOT in 2023 and 24. Dr. Killer is recipient of Iconic National Award MIC HWF in 2024, Iconic National Award IMA NDB in 2023, Bharatiya Manavata Vikas Puraskar by Daily Indian.com, Shushruta Award from Mass Healthcare in 2022, Chikitsak Ratan Award IMA HDB in 2022, International Broadcast Media Awards in 2020, and many more in his career till date. He has done, in fact, pioneer work in the field of induction therapy in renal transplantation and hemodiafiltration. His department has been accredited as a Center of Excellence for Hemodiafiltration. Well, it is once again my privilege to welcome such a stalwart in the field of nephrology to our platform. Very warm welcome to you, sir. Now, without any further ado, I'd like to hand over the session to Dr. Kullar. Over to you, sir.
Thank you very much, Dr. Vinod. Thank you, Intas. At the outset, my sincere thanks once again for this wonderful opportunity whereby I have been entrusted the task of inviting some of the best known names in the field of nephrology across the country. I'm privileged to have the affirmation by the best, whomever I've requested, have always obliged us by their gracious presence. Today is going to be no exception. Everyone who has joined, and we are flattered by the swelling numbers over a period of time. We are invariably having close to 2,000 people join us for this very important meeting, which we believe is a very great way of disseminating knowledge amongst all the physicians across the country when it comes to the nitty-gritties of chronic kidney disease and its management. We've had few successful editions of this series as well, starting with the definitions and then the symptomatology, and then we talked about how to manage diabetes in CKD, and then again hypertension in CKD. So this time we are in for something very, very interesting and very, very important, and that is the relevance of bone disease to the occurrence of chronic kidney disease. So something which has been given a different name from what we are familiar with many years ago. We used to refer it to as renal osteodystrophy, and then a whole lot of other names given to it. Currently, we favor calling it as chronic kidney disease, mineral bone disorders, mineral bone disease, whereby it's a spectrum. And we have none other than a brilliant nephrologist by the name Dr. Tarun Mittal. Tarun Mittal is a big name in this part of the country, at least. Can we have the previous slide, please? Yeah, the next one, Dr. Tarun's introductory slide, who is at the moment a consultant nephrologist at the Prime Kidney Care in Agra after doing his training from the prestigious All India Institute, no, or PGI Chandigarh. He has successfully completed the ISN ANIO Clinical Nephropathology Certificate Program in the year 2014 and 2015, and he has several publications to his credit in both national as well as international journals. So it's always a treat to listen to Tarun. Whenever I listen to him as at his various talks, I have been privileged to attend. It's a treat. It's they're mesmerizing. His concepts are so clear that it certainly I couldn't resist myself not asking him for this particular edition, and I thought he will do real justice to the topic for today with his large experience. And I think is a very a popular person amongst all his peer group here in this part of the country. Whenever it comes to academic activities, and he also is an integral part of our department's academic activities as well. So thank you very much, Tarun, for accepting our invitation today. So you are going to talk over the next about few minutes on the basics of chronic kidney disease and mineral-borne disease. Up next, after Tarun finishes, we will be joined by a galaxy of panelists. Some of, again, as is customary for me to inform the august audience that I am being joined by the best known faces in the field of nephrology across the country, and spearheading this group would be none other than Professor Amit Gupta. I think he needs no introduction, and it's, as I was telling everyone in this group before we went live, that it's a matter of privilege for me. It's a matter of huge honor for me, for Dr. Amit Gupta to have accepted our invitation today. One of those people whom I've always admired for his sheer brilliance, knowledge, passion, and you name it. And I think what a down-to-earth person Professor Gupta is. After superannuating as the head of the department of the one of the most prestigious institutions of the country. Can we have the introductory slide of Professor Amit Gupta, please? Um, from SDPGI Lucknow, he is currently the chairman of Department of Nephrology at Apollo Medics Super Specialty Hospital in Lucknow. Dr. Vinod, can we have the slide, please, for the audience to go through his introductory slide, please? Well, as I said, he was the professor and head at the prestigious SGPJ Lucknow, and one of the most admired, not just by his patients, his peer group, but immensely revered by all his students. And certainly, it's not just any particular field in nephrology that he is an expert at. Basically, a complete nephrologist, but certainly he is synonymous with whenever we talk about peritoneal dialysis in our country as well, for which he was awarded the fellowship of the Royal College of Physicians, London, UK, and is also the recipient of the prestigious Bayer Award by the Indian Society of Nephrology for his work in the area of peritoneal dialysis. This was as recent as 2024. And of course, the Pioneer Award by the International Society of Nephrology in 2025. He has been a member, a guiding force for the various guidelines committees, including that of the ISPD on peritonitis, both in 2005 and 2010. And he was also the past president of Indian Society of Nephrology, well recognized for all his tremendous efforts to promote the field of nephrology in our country, as well as he was the president of the Peritoneal Dialysis Society of India in 2004. He has numerous publications to his credit, all in the reputed journals. So, as I said, it's a big honor for all of us to have Professor Gupta join us today. So we'll be interacting with him during the panel discussion after Tarun has delivered his talk. Up next, it's my pleasant duty to introduce a very dear friend of mine, Dr. Gulliver Potsangam. He's currently working at Manipur, is the consultant nephrologist at Shija Hospital and Research Institute in Imphal. a very prestigious hospital in that area, doing a great service after finishing his training from PGI Chandigarh as a nephrologist after he had finished his MD from R&T Medical College in Udaipur. Whole lot of publications in the various reputed index journals, both national as well as international, and he has been a constant feature in various meetings across the country. A very important person from his part of the country doing a human service to a whole lot of patients from the northeast, where he is a very prominent and popular figure in the field of nephrology. So thank you very much, Gulliver, for giving us this opportunity to interact with you today. And we are going to request you for this wonderful panel discussion, which I'm quite excited to host today. Up next, we have Vinant Bhargav, and it's as a personal note, Vinant has been so close to me all these years, with my close association with him while I was there at my previous hospital. That's the prestigious Sir Gangaram Hospital. It's a treat to know Vinant, a wealth of knowledge, very down to earth person again, who has sheer brilliance reflected whenever he gives any talk, and it's always a treat to listen to him, and the way he brings home some of the very important points in a very easy manner for everyone to comprehend. Lot of experience. His practical experience is enormous. His clinical acumen, I can testify to that, having worked with him for so many number of years. So Vinant is phenomenal. Has written quite a lot of books now. Also, forget about just any publication in many of the prestigious journals. He has now the knack of coming out with a book practically every year now. So Vinant, thank you very much for joining us today. And as you can see, his key areas of interest within the field of nephrology are the vascular access biology and of course renal transplantation. He's edited a book on kidney transplantation, which has become very popular. Let me tell you, Vinant, that book has really become very popular. All the DM candidates also are really very fond of that particular one. So last but not the least, it's my pleasant duty to introduce another brilliant nephrologist. I am really amazed by the wealth of her knowledge, Jyoti Priya, who is currently a consultant nephrologist at the prestigious MGM Muthoot Medical Center in Pidhanamthitta, Kerala. She has presented research papers in various international, national, and state nephrology conferences. I know I have seen her progress from her student days, where she always came across as a brilliant student, and then she is transformed into over the years into one of the best known nephrologists in that part of the country. A sheer wealth of knowledge again, who is so passionate. You just have to listen to her podcast to know what kind of knowledge she wants to disseminate amongst her patients as well. So it's a sheer brilliance which gets reflected whenever she gives any talk, and I've had the opportunity to interact with her on a few topics, and I was amazed to know the kind of knowledge she possesses, and she has publications in various reputed journals, and of course, and she has her areas of interest within the field of nephrology are the glomerular diseases, renal transplantation, and of course chronic kidney disease. And no one better than her also to be talking about a very important facet of chronic kidney disease. That's the bone involvement or the mineral bone disease. So with this, let us move on to the agenda for today. And may I request Dr. Tarun Mittal to start sharing his slides. And over to you, Tarun. Looking forward to having a great kickstart to a great meeting for today. Thank you very much. Over to you, Tarun.
Yeah. Good evening, everyone. And first of all, I would like to thank the organizers for inviting me for this talk. And thank you, Dr. Kuller, sir, for that kind introduction. And today I'll be talking on chronic kidney disease, mineral and bone disorder. So we know that disturbances in mineral and metabolism are ubiquitous in chronic kidney disease and can lead to serious and debilitating complications as well as increased mortality. The manifestations of these disorders start to appear in early stage 3, that is when the GFR falls below 60 ml per minute, and they worsen progressively as the GFR declines. Understanding of these disorders has evolved over the last 2 to 3 decades, and I'll be talking about those in my presentation. So renal osteodystrophy, it is an older term, and it refers to the constellation of bone disorders which occur in chronic kidney disease. Now, however, it was realized over the last 2 to 3 decades that the manifestations or the spectrum of these disorders goes far beyond bony abnormalities. It also includes laboratory abnormalities, including hormonal abnormalities like disorders of parathyroid gland, FGF23 and vitamin D, as well as mineral abnormalities like disorders of calcium and phosphorus. And in addition, also includes vascular and other soft tissue calcification. So together, these bony abnormalities, lab abnormalities, and vascular calcification leads to increased cardiovascular disease, increased fractures, and overall increased mortality. And the term CKD-MBD was coined in 2006 to refer to the entire spectrum of these disorders as we understand it. Now, what leads to CKD-MBD? So we know that besides being very important excretory organs, the kidneys also play a very important endocrine role. And a key endocrine role is to activate the inactive vitamin D, which is either produced in the skin by ultraviolet light exposure or obtained through the diet, to active vitamin D, that is 125 dihydroxy vitamin D. And the kidneys play this important role. And as the GFR declines, two important things happen. One is because of the decreased excretory capacity, there is increased serum phosphate levels. And the second, because of the decreased endocrine function, there are decreased levels of active vitamin D in the body. These two abnormalities lead to decreased serum calcium levels, and together increased serum phosphate levels, decreased serum calcium levels, and decreased 125 hydroxy vitamin D levels. They are sensed by the parathyroid gland, and this leads to increased PTH secretion, or what is called secondary hyperparathyroidism. So in the initial stages, this secondary hyperparathyroidism is homeostatic, it is beneficial and tries to revert these basic abnormalities which are leading to it. However, beyond a certain point in time, this becomes maladaptive and leads to the bony abnormalities and the vascular calcifications. Our understanding of the pathogenesis of CKD-MBD has evolved with the discovery of this hormone FGF23. FGF23 happens to be the first hormone to rise in CKD-MBD. It has two basic functions. One is to increase the phosphorus excretion by the kidneys and therefore to maintain normal serum phosphate levels. At the same time, it suppresses the activation of vitamin D and decreased levels, and this leads to decreased levels of 125 dihydroxy vitamin D, or the active vitamin D. This decrease in active vitamin D is sensed by the parathyroid glands and leads to the downstream harmful effects. Also, nutritional deficiency of vitamin D, inactive vitamin D, would again lead to decreased levels of active vitamin D and again lead to increased PTH levels. So the way the FGF23 hypothesis has kind of improved our understanding is that now we understand why PTH levels rise much earlier in chronic kidney disease, even when these electrolyte abnormalities, that is serum phosphate levels and serum calcium levels, they are normal. However, the increase in FGF23 early in CKD actually leads to the rise in parathormone levels much earlier than these electrolyte abnormalities. Now, this picture again explains the temporal course of these hormonal and mineral abnormalities. So FGF23 is the first hormone to rise, and this rise occurs as early as late stage 1 or early stage 2. This is followed by a fall in active vitamin D levels, as can be seen in the striped blue lines. And this is followed by a rise in the PTH levels. And as you can see, these abnormalities are progressive. However, these are still able to maintain the phosphate levels within normal limits until late in the course of the disease. And when these homeostatic hormonal abnormalities fail, and in stage 4 or 5 CKD, finally the phosphate levels tend to rise and the calcium levels fall. Now, what is the prevalence of these mineral and hormonal disorders? As early as the GFR, this on the x-axis we have the GFR values, and as early as stage 2 CKD, that with approximately at a GFR of 80, almost 10% of patients would be having secondary hyperparathyroidism. This prevalence would steadily and progressively increase, and by the time patients reach a GFR of less than 20, almost 90% would be having secondary hyperparathyroidism. The prevalence of hyperphosphatemia and hypocalcemia is lesser, and even at GFRs less than 20, approximately 40% would be having hyperphosphatemia, and 20% would be having hypocalcemia. Now, how do you diagnose these abnormalities? And I'll be talking about the diagnosis of the mineral disorders, the bony disorders, and the extraskeletal calcification separately. So, the diagnosis of mineral and hormonal disorders is straightforward. It is done through blood levels. And we, as I've already discussed, the pattern that we see in the CKD MBD is increased FGF23, decreased active vitamin D levels, increased PTH levels, increased phosphate levels, low calcium levels, and low inactive vitamin D levels. Importantly, calcium levels should always be corrected for serum albumin when you are interpreting them. Now, on a day-to-day basis, while we are managing patients clinically, FGF23 levels we do not measure. These are only available in research labs. In addition, again, active vitamin D levels are not used because active vitamin D has a very short half-life, and the levels do not actually help us in clinical management. So we practically use only PTH levels, phosphate and calcium levels, and inactive vitamin D levels. Now, it is also important to realize that the trends are actually more important than one-time values. So we need to have serial measurements before we can take clinical decisions as to what therapeutic changes we want to make. And the frequency of these measurements would vary depending on the stage of CKD. So in stage 1, one would begin the screening for these disorders in early stage 3, that is stage 3A. And at that time, the screening would be somewhere between 6 months to a year. Whereas in patients with advanced disease, for example, patients on dialysis, one would screen for these disorders every 1 to 3 months. Now, moving on to the diagnosis of bone disorders. So, the bone disorders in CKD MBD can be broadly categorized into high turnover bone disease and low turnover bone disease. High turnover bone disease is the direct manifestation of secondary hyperparathyroidism. So, what increased parathyroid levels do is they actually act on the bone to increase both osteoclastic and osteoblastic activity. And so there is more bone resorption and more bone deposition. And as this bone turnover moves, in the natural course, it weakens the bone and leads to bony pains, pruritus, and fractures. In low turnover bone disease, exactly the opposite happens. So there is decreased cellular activity, both osteoclastic and osteoblastic activity is decreased. The bone is thinned out, and it can also be unmineralized, as can happen in osteomalacia. So there are two types of low bone turnover disease: adynamic bone disease and osteomalacia. Low turnover bone disease is actually thought to be more harmful than high turnover bone disease because the bone here becomes inactive. It is unable to take up any calcium, and so the circulating calcium actually in low bone turnover disease goes and gets deposited in the vessels and soft tissues, and these patients are at a higher risk for cardiovascular death. Now, unfortunately, short of a bone biopsy, it is very difficult to be very sure whether we are dealing with high turnover bone state or a low turnover bone state. And bone biopsies are seldom performed because they are invasive and they need specialized laboratory and personnel. However, what has been shown is that we can use PTH levels with or without bone specific alkaline phosphatase levels to kind of predict the underlying bone turnover states. So if the PTH levels and the bone specific alkaline phosphatase levels are high or are significantly high, that would mean that the underlying bone turnover is high. Whereas if the PTH levels and the bone specific alkaline phosphatase levels are significantly low, they would indicate a low bone turnover state. Now coming to the diagnosis of vascular and soft tissue calcification. So again, this can be done through lateral abdominal X-rays. So in this figure, you can see this is the normal figure where you cannot make the aortic outline. However, in CKD MVD with vascular calcification, the aorta becomes so heavily calcified that you can actually make out the entire outline of the aorta. On echocardiography, you can look for myocardial calcification and valvular calcification, and identifying soft tissue calcification and vascular calcification. Actually, we are able to identify the patients at the highest risk for cardiovascular mortality. So this is important to identify. These abnormalities are important to identify. Another very serious manifestation of vascular and soft tissue calcification is calciphylaxis. Here, the small and medium-sized vessels tend to calcify and get thrombosed, and this leads to ulcerations, necrosis, and this condition again has a very high mortality. Now, how do you go about managing these patients? So I'll refer back to my figure on pathogenesis, and the broad goals of management are first to control serum phosphate levels, and secondly to prevent and treat secondary hyperparathyroidism. And while we are doing all this, to avoid PTH oversuppression and hypercalcemia, because this can lead to the low turnover bone state, which we want to avoid. So I've marked the levels of intervention with red. So our first goal is to normalize serum phosphate levels. So serum phosphate, as I have already discussed, is an important inciting factor for the downstream maladaptive pathway. But in addition, serum phosphate levels have been independently associated with mortality in CKD patients. So it is very important to normalize serum phosphate levels. The second goal of intervention is to replace inactive vitamin D. And finally, we have two broad groups of drugs that can be used to directly suppress the PTH, the increased secretion of PTH. One is active vitamin D, and this would act through the vitamin D receptors on the parathyroid glands to decrease PTH gene transcription. And then we have calcimimetics, which acts through the calcium sensing receptor on the parathyroid gland and therefore decrease PTH secretion. And I'll be talking about each of these interventions one by one. So let's talk about how we treat hyperphosphatemia in CKD patients. So the phosphate lowering interventions that we have are a dietary restriction of phosphate, drug therapy, that is phosphate binding agents, and in patients on dialysis, we tend to optimize the dialysis dose because dialysis is an important modality to remove phosphate from the body. We start dietary restrictions once the serum phosphate goes beyond 4.5 milligrams per deciliter, and we start thinking about drug therapy once the serum phosphate goes above 5.5 milligrams per deciliter. What is our goal phosphate levels when we are doing all these interventions, particularly the drug therapies? The guidelines do not give us a number. They just say that we are supposed to bring phosphate levels near normal range. But a practical goal is to bring phosphate levels to below 5.5 milligrams per deciliter. Talking about dietary restrictions, the first and foremost advice that should be given to patients is to avoid processed foods and beverages, because these foods and beverages have inorganic phosphorus, which is free phosphorus, which has more than 90% bioavailability, and it is readily absorbed in the intestine. So foods like fast food, packaged foods, chips, namkeen, pickles, sauces, frozen meals, pizzas, cold drinks, chocolate drinks, etc. should be completely avoided. Between vegetarian diet and non-vegetarian diet, the phosphate in vegetarian diet is bound to phytates. And the human intestine does not have the enzyme phytase. Therefore, phosphate in the vegetarian diet is poorly absorbed. So vegetarian diet is kind of the preferred diet when it comes to phosphate management in CKD patients. Dairy products are another rich source of phosphorus, and items like processed cheese, ice creams, puddings, and cream soups should be completely avoided. Milk and yogurt, being staple in the Indian diet, can be allowed in moderation. Now, moving on to phosphate binders. We have two broad groups of phosphate binders that are available: calcium-based binders and non-calcium-based binders. Calcium-based binders are relatively inexpensive and have been used for a very long time. However, the current guidelines actually suggest avoiding them because it has been shown and there is evidence to suggest that they can lead to hypercalcemia, PTH oversuppression, and increased cardiovascular mortality. So nowadays, there is a preference to use non-calcium-based binders, and there are different binders available like sevelamer, lanthanum, iron-based binders like ferric citrate, sacroferric, oxyhydroxide, and all of these are available in the Indian market and can be used. Just a word of caution about aluminum and magnesium-based binders. They are no longer used and no longer probably available also. But from history, we know that the use of these binders was led to many harmful effects like anemia, uh, osteomalacia, and even encephalopathy in late stages. Tinapinor, this is a new drug which is FDA approved for use for controlling hyperphosphatemia in dialysis patients as add-on therapy when you're not able to control phosphorus with dietary restriction and the regular phosphate binders. This is a sodium hydrogen exchanger 3 inhibitor, and it prevents phosphate absorption in the intestine. This is probably not still available in India. Now, the second level of intervention is to replace inactive vitamin D. So we know that inactive vitamin D deficiency is common in the general population and is similarly very common in CKD patients. And this deficiency has been associated with elevated PTH levels. And what has been shown is that replacement of inactive vitamin D can modestly suppress PTH levels. So it is recommended that levels should be checked at baseline and they should be replaced if they are low. And low is defined as less than 30 nanograms per ml. The dosing is around 1000 to 2000 units per day, and one can give the 60,000 units sachets or capsules or liquids that are available every 1 to 2 months for replacement. One should be cautious because inadvertent overdose can lead to serious vitamin D toxicity. Now, the next intervention that we can do is to use drugs to suppress PTH levels directly. And as I've already mentioned, we have two broad groups of agents: active vitamin D and calcium mimetics. Now, before I go on to these individual agents, it is important to understand as to what PTH level are we targeting. So where do we start and what do we target? Now, unfortunately, for patients not on dialysis, the optimal PTH level is not known. So we do not know exactly, when should we start and what should be our goal. It is suggested that patients who have PTH levels which are progressively rising or persistently above the upper limit of normal. So the upper limit of normal in the usual assays that we use is 65 picograms per ml. So if patients are having levels which are progressively rising or persistently above this level, the first step should be to apply the interventions that I've already talked about, that is treating hyperphosphatemia or treating vitamin D deficiency. And only if these levels remain persistently high or they are progressively rising, then one can use the active vitamin D or vitamin D analogs to control hyperphosphatemia for non-dialysis patients. The use of calcium mimetics is not very evidence-based, and the guidelines are silent on the use of calcium mimetics in non-dialysis patients, although they are used practically. For patients on dialysis, we have little more data, and it is recommended that PTH levels should be kept between 2 to 9 times of the upper limit of normal, and that would translate to levels between 150 to 600. And if on serial measurements the levels are moving in one direction or the other, and they are moving out of this range, then one can use therapeutic interventions or one can change our therapeutic strategy to maintain levels within this range. And in patients on dialysis, one can either use active vitamin D or vitamin D analogs, or can use calcium mimetics or a combination to maintain levels within this 2 to 9 times the upper limit of normal range. If patients are having persistent hyperparathyroidism despite all these interventions, then one can go for surgical parathyroidectomy. Now, a word about active vitamin D and analogs. We have multiple agents available: calcitriol, pericalcitol, doxorcalciferol, and alpha-calcidiol. The commonest one used is calcitriol, and it is dosed at 0.25 micrograms per day to 0.5 micrograms twice a day. Now, the very important message here is that active vitamin D should not be a part of every CKD prescription. So when I was a resident 20 years back, that is what used to happen. Active vitamin D was probably prescribed to every CKD patient. However, nowadays the recommendation is that one should use active vitamin D with a very specific goal in mind, that is to suppress PTH levels. And although I've already told you the guidelines do not give you a number, but in general, the practical point is that usually one would not begin active vitamin D use unless the PTH levels are above 300 picograms per ml. Also, one should be very cautious not to oversuppress PTH levels when we are treating with active vitamin D, because that can lead to adynamic bone disease, and active vitamin D should be stopped if the PTH levels fall below 150. So again, this is not evidence based or guideline based. These are just practical numbers that we usually follow when we are treating patients. One should always also remember that active vitamin D use leads to hypercalcemia and hyperphosphatemia because of increased intestinal absorption of these minerals, and therefore one should be cautious and should monitor for these abnormalities, and if they occur, one should stop active vitamin D use. Calcium mimetics, I've already told you, they act through the calcium sensing receptor on the parathyroid gland. We have two agents. Cinacalcet is given orally, dosed at around 30 to 180 milligrams once a day, and ethyl-calcetide is given intravenously thrice a week at the end of dialysis. The most important side effect to remember with calcium mimetic use is hypocalcemia. Although mild asymptomatic hypocalcemia is acceptable while you're using these agents, if the calcium levels fall below 7.5, one should stop these agents and start at a lower dose once the calcium levels come up. And if there is baseline hypocalcemia, then probably one should avoid starting these agents as well. Parathyroidectomy is generally considered for refractory cases, usually when the PTH levels are persistently above 800 to 1000 picograms per ml. And the final word is about calcium levels. So whereas earlier guidelines used to emphasize on attaining normal calcium levels, the current guidelines say that the emphasis should be on avoiding hypercalcemia. Mild asymptomatic hypocalcemia is permissible when you are treating CKD-MBD. However, hypercalcemia should be definitely avoided. So one should monitor serum calcium levels while they are on treatment and avoid calcium-based phosphate binders for that reason, and also stop active vitamin D in case there is hypercalcemia. My last slide on about the management of osteoporosis in the presence of CKD-MBD. So for early stages of CKD, that is stage 1 to 3, without any evidence of biochemical abnormalities, one can treat patients as osteoporosis is treated in the general population with bisphosphonates and denosumab and teriparatide, etc. However, the difference that has come in our understanding is in patients with later stages of CKD with biochemical abnormalities who have biochemical abnormalities to suggest underlying CKD-MBD. So earlier we did not have evidence that DEXA can be used in patients with advanced CKD to predict fracture risk. But now gradually the evidence is accumulating that actually DEXA can be used in these patients. And the current guidelines say that you can use the DEXA to predict fracture risk even in advanced CKD. Also, we have gained experience in the use of anti-resorptive therapies in advanced CKD, particularly denosumab. So now we are more confident with the use of these agents in advanced CKD. And earlier, the guidelines used to recommend that a bone biopsy should always be performed when you are thinking of giving anti-resorptive therapies in patients with advanced CKD stage 4 or 5. However, the guidelines are now more relaxed, and they say that you may consider doing a bone biopsy, but you may not always insist on it. So in summary, this is my final slide. Manifestations of MBD or mineral and bone disorder appear early in the course of CKD and are progressive. You need to actively screen patients for the mineral and bone abnormalities, and serial measurements are important. And management is aimed at controlling serum phosphate levels and countering excess elevation of parathyroid hormone without causing oversuppression and hypercalcemia. Thank you.
Thank you very much, Tarun, and I'm sure everyone would agree we couldn't have asked for anything better than just a great overview of a very, very important talk. People often wonder as to why nephrologists are all the time wanting to become a talk like orthopedic surgeons. So, but I think we have a solid reason. We have a very, very valid reason, because we do understand that the way we take care of some of these electrolytes and the biomarkers, I think probably no one else can do a better job than a given nephrologist. So this is what we are going to discuss today. Thank you very much, Tarun. And may I now invite all the elite panelists for today's discussion. I'll begin by asking Professor Amit Gupta a very, very basic question. So we Tarun very nicely talked about the pathophysiology, and we at the end of the day do understand it's an interplay between the vitamin D, which was supposed to come from the kidneys, and its effect on the intestine to absorb calcium, take care of the phosphorus, as well as suppress and control parathyroid hormone. And over the years, we have realized the importance of markers like FGF23 and its action via clotho. So can you just briefly sum up as to when do you believe these things happen in a typical patient of chronic kidney disease? Because by the time we generally believe we are sensitized to the occurrence of mineral bone disease, probably a lot has already happened with the bones of a given patient. So what in your practice is the starting point to look for this? Professor Gupta, sir?
Yeah.
Dr.
Yeah.
Yes, sir.
First, let me congratulate Tarun for this excellent presentation. Actually, I never really understood this topic very well, even though I've spent 40 years in nephrology. But today, Tarun explained it so well in such a brief period of time that things became very clear. And so that's a great job you did, Tarun. And thank you very much for it. Now, regarding the question that you asked, that when should we start looking at mineral bone disease? As Tarun said in his presentation, really the manifestations start when the GFR drops to less than 60, that is stage 3A. Although the levels of FGF23 as well as PTH start climbing up even in late stage 1 or during stage 2. But but at that point of time, looking for CKD, MBD, we may not not be able to reach a diagnosis. Apart from the fact, because hyperphosphatemia will only occur when you have reached stage 3 and beyond. Before that, the phosphate levels are taken care of by the elevated rises of FGF23 as well as the PTH, as you showed in that graph, that these two hormones start increasing right from the time in stage 1 and perhaps in stage 2. But the hypophosphatemia will become evident only in stage 3, essentially because the reduced number of nephrons that are available. So I think we still will like to screen patients only from stage 3 onwards. That is what I consider. What is your opinion on it and the rest of the panel?
Oh, thank you very much. I think that's very, very practical. You see, because at the end of the day, after assimilating all this knowledge, we have to be practical, and we have to make our treatment modalities as cost effective as possible. So we'll come back to everyone and try to learn from their experiences. But one question here, Vinod, Professor Gupta said that it typically happens, and this is which we all believe, that hyperphosphatemia happens only once a significant damage has been done to the kidney function. But we are also aware of that entity called a transient hyperphosphatemia or a postprandial hyperphosphatemia, which happens rather early. early, and obviously no one gets to know about it, no one notices it, and it may just be, as I said, a very transient phenomenon. Do you give any importance to that, or would you also agree that yes, we can be complacent in the initial stages and then try to look for something meaningful that may have happened to the patient's kidneys, to the bones, as a result of CKD rather late in the course of the illness? Vinant?
At the outset, thank you, sir, for the for a lovely panel collection over here, and to Tarun for having presented such a great presentation once again. And sir, this is a very pertinent question. And in fact, before we could sit in the panel here, I was just wondering if any such concept would actually make any difference. But when you look at the presentation that Tarun has given here, phosphorus appears to be a phosphotoxin, in fact. So phosphorus is not just to do with rise in FGF23 or causing a downstream event in which the PTH rises and causes mineral bone disease. But phosphorus is also phosphotoxin and has been also shown to have some amount of cardiovascular damage and causes long-term cardiovascular events too in patients with CKD. So I think the question about the fact that intermittent phosphorus rise is a very, very important concept. And unfortunately, all the binders that we have till now bind the phosphorus only at the level of the gut. And we have very few binders or very few agents that actually can stop the paracellular movement of phosphorus, which occurs every time you take a meal in which the phosphorus is given. So not all the binder is going to bind to all the phosphorus in the food. There's going to be some phosphorus that moves through the paracellular pathways. So I think there is some role of tenapanor in those patients, and the concept is very well taken, sir.
So before we proceed any further, Dr. Gulliver, my question to you is, well, what is your practical take and your message to all those who have joined us today? What kind of tests should they have in mind? Because we have talked about, Tarun has talked about the role played by calcium, phosphorus, PTH, and FGF23. Let's try to make it as practical as possible for all those who have joined us today, taking care of the patients in the far-flung areas of the country. So which all tests would you advocate to the patients of chronic kidney disease where you want to know whether he or she has a significant or a meaningful mineral-borne disease as well?
So, sir, regarding test and regarding signs and symptoms which we have, the patients which we see in our country, when we compare the literature with other countries, the population is different. We have a relatively younger CKD population compared to those in the Western population. So the signs and symptoms will be different when we compare. So the fractures regarding clinical manifestations, the symptomatic CKD MBD will be, I think, will be a problem only in the extremes of age. So in the younger age group, in which they can have bone deformities and rickets, in the elderly age group, when they can have osteoporosis, and anyway they are more prone to fractures. So CKD MBD, I think by and large, this is asymptomatic in the younger age group which we face. So investigations are important. We will need to do the investigations such as calcium, phosphorus, PTH, according to the SAID guidelines, which was very well elucidated by Dr. Tarun, and the frequency would be guided according to the stage of chronic kidney disease. FGF23, sir, I think it's not commonly done, though it is available and it's quite expensive. So since the main emphasis would be on phosphorus, I think calcium and phosphorus levels need to be more frequently done, and so also PTH. The replacement of vitamin D is important because that is one of the prime drivers of vitamin D deficiency. Is also one of the prime drivers of hyperparathyroidism. So replacement is important. So vitamin D levels should also be tested as and when indicated.
Thank you very much, Dr. Gulliver. This one is for you, Dr. Jyoti Priya. So taking it further, I mean, and at the same time, trying to make it very cost effective to our general patient population, where, of course, expenses are certainly topmost in everyone's mind. How often, based on the guidelines which Tarun had suggested, what would be your suggestions to the fellow physicians as to how often we should test for the kind of tests which Dr. Gulliver has told us to do in terms of the calcium, phosphorus, and at the same time, may I ask you the kind of levels which you have in mind for these patients when you talk about the two most important things, that's calcium and phosphorus.
Thank you, sir. At the outset, thank you so much for giving me this amazing opportunity. So, regarding the test for CKD-MBD and the frequency of the measurement, see, first of all, we know the main parameters we have in our mind in assay is calcium, phosphorus, intact PTH. So the problem is, unless the CKD goes to stage 3, 4, and 5, in early stages, it is difficult to pick up changes in calcium, phosphorus, as well as PTH. So early stages, as Sir rightly told, FGF23 is one of the marker which rises, but we don't have a validated commercially available assay for it. So we depend on calcium, phosphorus, and PTH. Now, problem with calcium and phosphorus, until we reach the stage 4, stage 5 and all, we won't get gross abnormalities in calcium and phosphorus, especially in early stages of CKD. And PTH start increasing probably when the EGFR falls below 60 ml. But again, the problem with PTH is in non-dialysis CKD population, we don't have a well-established reference range. Though we say in dialysis population 2 to 9 times the upper limit of normal, in non-dialysis, we don't have an established range. And another thing, we can't depend on one value, because we know about the skeletal resistance, and many times, even when the PTH is high, the spectrum of bone disease may be a dynamic one and vice versa. So when you are resorting to the initial assays, probably when you see a patient at the initial visit, we can have a calcium phosphorus baseline evaluation and PTH if patient is affordable. And we have KDIGO guidelines on all these assays, but practically what I do is in my first visit, I'll check calcium and phosphorus and PTH if the patient is affordable. And in subsequent visit, probably once in 6 months, calcium phosphorus in early stages of CKD. And as CKD stage advances, the frequency will increase. Now, regarding the level I have in mind, see what I do is rather than a single value of PTH, I try to go for a serial value. And if possible, I'll club it with a bone specific ALP. I know bone specific ALP is many times not available in all the hospitals, but if available, that is the best one because that will give an exact picture of what is happening inside the bone. So calcium, phosphorus in early stages, probably once in 6 months. And as the stage advances, once in 3 months. And in late stages, probably once in 2 months. And PTH value, a serial value, if patient is affordable, combined with a bone specific ALP. So that will be my approach. And regarding all these values, again, an individualized approach I'll be taking, and the frequency also based on the initial values, it will change.
Well, that's very practical approach. Thank you very much for sharing your thoughts. And I think we, as I said earlier, will have to strike a balance between science and the pocket of the patient as well. So points well taken. And I think wherever it is.
Can I just butt in? These lab values also have to take into along with the clinical features or symptoms, because that would be another important thing, you see, to decide how frequently you want to get it done.
Yeah. So quite true, sir. And I think the whole reason for asking this question was that there is a lot of confusion and ambiguity when a physician comes across these reports and doesn't know what to do. So I think with that in mind, and from what we've heard from Tarun today, may I ask the guru, that's Professor Gupta, as to how does he treat hyperphosphatemia? I mean, we did hear from him that traditionally we were all using, starting from our good olden days where we reposed our faith in aluminum hydroxide, and then we realized, no, it's a big no because you can get aluminum toxicity. But then all these years we had favored calcium-based supplements, at least in our country. And now suddenly we keep on hearing some horror stories about calcium and the calcification which it can cause. So we are shifting away from calcium-based, more in favor of non-calcium based such as sevelamer carbonate or lanthanum carbonate, or even the iron preparations related preparations. So what in your experience you've been doing in the past and now what you are doing currently in 2025 managing hyperphosphatemia? And what is that, one more time, cutoff where you will begin giving them, at what level, and when would you stop?
Yeah. So actually, now the traditional thinking is that it is not just giving phosphate binders, but it's basically phosphate lowering therapy that you would sort of look at. So therefore, you'd start off, as Tarun mentioned, that the first thing would be to sort of counsel your patients about the diet and look at things that they should avoid in order to reduce the phosphate levels. That's the first thing. Then subsequently, you can look at phosphate lowering agents, which could be either in the form, earlier we used to use calcium-based binders. Can you hear me? Am I audible?
Yeah, it's fine now. We had a brief lapse, but now you're back.
My internet connection is a little
no, it's fine. Absolutely fine.
So first is diet. Diet is the important thing about, I mean, you need to counsel them about what food items to avoid so as to reduce the chances of their having hyperphosphatemia. Subsequent to that, once your levels are in excess of 5.5, that's the point when you would like to sort of suggest adding on a phosphate binder. Earlier, we were using calcium-based phosphate binders, which because they were cheap and effective. And but as the KDO guidelines have suggested that this calcium-based phosphate binders can lead to hypercalcemia and vascular calcification and coronary artery disease, etc. So we have moved on to the non-calcium-based phosphate binders. The problem with this, with all types of phosphate binders, whether it's calcium-based or non-calcium-based, the pill burden increases substantially. So that is why the compliance to many of these drugs is also is less, because many patients may take it for a few months and thereafter they may not take the number of drugs that you have, a number of pills that you have advised them to take. And there's some thinking that if you combine calcium and magnesium, perhaps you can reduce the chances of hypercalcemia. So because in India, cost is a major issue. One of the reasons for non-compliance is because the number of pills are too much, and second, the cost of therapy. So I think we'll have to strike a balance. You need to be careful with the number of medicines as well as make it not very expensive for the patient. So I think the goal would be 5.5 would be the level at which you may consider adding a phosphate binder. But prior to that, make sure that the patient doesn't take food items which are rich in phosphorus. And as Tarun pointed out, vegetarian diet is perhaps better off as compared to non-vegetarian, so that patients can be counseled with that.
Very, very useful information. And I think one practical aspect, I'm sure Dr. Gupta and others would agree with me, that it's also important to have a look at the calcium level of a given patient, because typically by the time they come to us as nephrologists, the phosphorus is something like 6, 6.5 or 7, and the calcium may just be about 7. So maybe ignoring the risk of calcification initially, we may go in for calcium-based phosphate binders, so which will serve a dual purpose. So I think your time-tested calcium carbonate or calcium acetate may suffice initially when you also are wanting to take care of phosphorus. And I think it's important to note the timing of a phosphate binder, because please, everyone should remember that it should be given at the time of patient having their meals, because otherwise it's not going to be of any use. So you basically want to get rid of the phosphorus from the dietary component rather than delaying the introduction of a calcium or a phosphate binder. So with that in mind, I think let's go on to the symptomatology. And I think one of the very nagging symptoms, I'm sure everyone would agree, is the intractable pruritus, which many of our patients get. And as the situation worsens, it becomes more and more distressing for the patients. Thankfully, with the kind of newer dialysis modalities and the kind of phosphate binders we have, it is not as grave a problem as we used to encounter till I would say a couple of decades ago. But still, we do encounter a lot of pruritus. So, Vinod, can I ask you as to what, in your experience, is your way of tackling this very nagging symptom, that is intense itching, which many of our patients do get? Yeah.
So itching, sir, as you rightly put, it's the most nagging symptom, and it's the most nagging for any nephrologist also to treat, because the first point when you're treating itching is to allay the symptoms of the patient and not just look into the fact that why the itching is taking place. The most common point of itching is obviously some metabolic causes such as hyperphosphatemia as well as hyperparathyroidism. So once you've taken care of both of them, there's another cause which is also caused as uremia, especially in patients who are either underdialyzed or patients who've not started dialysis at all. So it's quite a painful task actually to treat patients pre-dialysis, especially when they come to you with itching and using either antihistamines or maybe even gabapentin, opioid receptor blockers. I think that's the way we generally go. Once they go on to dialysis, intensification of dialysis, as well as seeing to it that their phosphorus levels are below the goals at the goal that is expected for a CKD5D, and the PTH levels to be maintained as close as to the point of 2 to 9 times, that is between 2 to 3 times. I think that's where it generally that's the thing. It's not just the electrolytes. I think it's also the uremia also.
Thank you very much, Vinod. And I think it's very important. We are having newer drugs. Of course, gabapentin came to our patients' rescue, which we realized its potential about a few decades ago. And I think this certainly has revolutionized the current management. Also, we give a lot of importance to the dryness or xerosis of these patients, the skin manifestations. We have been, in addition to the conventional antihistaminics, also been trying drugs like local topical applications of tacrolimus and other things. And we have a lot of new drugs also. But thankfully, the situation is not as grim as it used to be till a few years ago. And one of the reasons, which Vinant pointed out, was the role played by not just phosphorus, but also the parathyroid hormone. We have been listening a lot, and I think it's for those who have joined us today to have some clear-cut messages as far as the PTH values are concerned. We have heard from Tarun that we don't have an answer. If 70 is the upper limit, 70 picograms is the upper limit of PTH in a normal person, we don't know. All that we know is that it increases as the disease advances. So here it will be very important for everyone to be able to differentiate between primary, secondary, and tertiary hyperparathyroidism. It's easy. You see, if the calcium is high and the parathyroid hormone is slightly high, and the patient has symptoms, especially like high calcium, in all probability, we are dealing with primary hyperparathyroidism, probably which has nothing to do with CKD. But in a given patient of CKD, the typical story is a low calcium, high phosphorus, high parathyroid hormone, and that typically is in the range of to begin with 100 and 150, goes up to as high as 500, 600, or even 800 as the disease progresses and patient is on dialysis. Now, it's important also to remember another entity called a tertiary hyperparathyroidism, whereby suddenly one of the four glands becomes autonomous, and now the situation takes a twist, which means the low calcium, which was a stimulus for high parathyroid, now that gland starts producing a lot of PTH. The parathyroid hormone typically goes to something like 1500, 2000, even 4000, ridiculously high. But now the difference is the patient's calcium goes up. So if you encounter a low calcium and a high PTH, you are probably encountering a secondary hyperparathyroidism. While if your patient has high calcium and high PTH, probably, and ridiculously high ones at that, in a given patient of advanced stages of CKD, you're probably dealing with tertiary. And here the treatment is surgical. Here the treatment would be probably a radiofrequency ablation if your patient is not fit. But let's not talk about primary, let's not talk about tertiary. Let's focus to CKD and mineral bone disease. With that in mind, my question to Dr. Gulliver, please let us know, we've heard, and what are your thoughts on the kind of PTH values which you would allow in your patient in the pre-dialysis stage and the post-dialysis stage? What do you typically do when you encounter a parathyroid hormone of about 150 in a patient who just has a creatinine of about 2.5 or 3, and a GFR of about just about 25 to 30? And vis-a-vis a patient who is already on dialysis has a PTH value which is very, very high, something like 600. Over to you, Dr. Gulliver.
Oh, sir. As Dr. Tarun has rightly pointed out, in patients pre-dialysis in CKD stage, non-dialysis patients, we do not know the exact level of PTH which has to be kept. That being said, sir, it is recommended that some societies have given a value around 2.3 to 3 times the upper limit of the PTH assay. If we encounter such levels, then we may then we will need to look at other treatable causes like hyperphosphatemia, hypocalcemia, vitamin D deficiency. So those need to be corrected. Those need to be corrected first. And if there is and another thing is that we need to look at the trends. A single value will not suffice. So as Dr. Jyotipriya had pointed out previously, she would look at the trends in which the direction in which the PTH is going. So when we follow the trends serially, if there's a rise in serum PTH, then we would need to take definite action in pre-dialysis patients. As such, a single value of 150 will not help us much in deciding the course of management in such patients. And regarding the treatment of secondary hyperparathyroidism in non-dialysis patients, they have not been shown to have any. They have not been shown to influence the heart outcomes. Yes, we need to treat them in order to prevent the further progression to irreversible bone disease and other parathyroid hyperplasia, progression to parathyroid hyperplasia or autonomous hyperparathyroidism when they go on to dialysis. But for the treatment of heart outcomes in pre-dialysis, the treatment of secondary hyperparathyroidism has not been shown to help. Now, regarding dialysis patients, yes, the levels should be between 2 to 9 times of the upper limit of the said assay. That being said, here also we need to see the serial trends. If we have a higher value, then we need to do it more frequently and treat accordingly. According to if the patient has hypercalcemia, then we may need to institute calcimimetics along with the calcitriol, which we have been giving. And if the patient has hypocalcemia, yes, then it would suffice to treat with vitamin D, active vitamin D. The parathyroidectomy should not be thought of if the PTH is less than 1,000. So if the PTH goes above 1,000, 1,500, beyond 2,000, then parathyroidectomy should be thought of, and we should investigate further to see for autonomous gland hyperfunction. That would be my take on hyperparathyroidism, sir.
Yeah, very appropriate. Thank you very much, Gulliver. Dr. Jyotipriya, so he mentioned about calcimimetics. What in your experience now, and he also referred to the occasional need for parathyroidectomy. So may I invite you to comment on these two? When would you really start looking for taking the help of calcimimetics? What are the typical parathyroid hormone values which will compel you to seek the help of calcimimetics? As for those who the non-initiated ones, it's available as cinacalcet in our country, which as Tarun had alluded to, works at the calcium sensing receptors. But the practical approach, Dr. Jyoti, would love to hear from you.
Thank you, sir. So, cinacalcet or calcimimetics, what we have in our practice, what we use is cinacalcet. So, that is actually a potent PTH suppressor. So, in my practice, I when the patient is coming with a secondary hyperparathyroidism, in non-dialysis population, actually it is much more easier to control the secondary hyperparathyroidism in non-dialysis population compared to the dialysis one. So with a conventional calcium, calcitriol, phosphorus binder and dietary restriction, this secondary hyperparathyroidism is somewhat amenable to treatment in non-dialysis cases. So cinacalcet as such, I reserve for dialysis population. There are 2-3 things. One of the side effect of cinacalcet is hypocalcemia. The second thing is cost. So if we can control with other agents in the non-dialysis population, it is better to go with the other agents like phosphate binders and our vitamin D supplementation. And second thing, the studies in non-dialysis population are not that much like what we have in the dialysis population. Now, my take on cinacalcet is I reserve this drug for usage in the dialysis population where my secondary hyperparathyroidism is not getting controlled with our conventional methods like phosphate binders, phosphorus restriction, dietary phosphorus restriction, calcium, calcitriol, and then I'll resort to the cinacalcet. And second thing, in tertiary hyperparathyroidism, where surgery is not feasible because of frailty, comorbidities, and other issues, in such cases also, I'll use cinacalcet as an agent to lower the PTH level. So these are the 2 instances where I resort, but I know there are many nephrologists using in non-dialysis population, but my experience is limited to the dialysis population. And as such now, this is what generally practiced.
No, I'm certainly there with you, and I think this is a very strong message. It's actually not approved for use in a pre-dialysis patient, so we should refrain from doing that. And 2 other very important messages I would certainly want to convey today. One, of course, as she has very rightly pointed out, one of the common side effects is hypocalcemia, and we have no business to start cinacalcet in our patient unless we have corrected hypocalcemia. That's one. And in the same breath, I would say we have no business to start vitamin D supplementation, especially the activated one, till the time serum phosphorus has been brought under control. Otherwise, you'll be doing more disservice to the patients by giving them something which was not supposed to be given at that point in time. So, Dr. Jyoti, do you believe the need for parathyroidectomy has come down with the drugs like cinacalcet and our better understanding of the way we should be giving or using activated vitamin D in our patients? Or do you believe still quite a number of times we have to resort to parathyroidectomies even in our patients of secondary hyperparathyroidism?
It has definitely come down with these newer agents like calcium mimetics compared to the olden time where we frequently have to resort to the parathyroidectomy for secondary hyperparathyroidism. Because of the timely use of these agents and our knowledge of the calcium phosphorus balance and the usage of activated vitamin D, when to use and when not to use, this understanding and the newer agents has definitely helped in bringing down the incidence of the parathyroidectomy surgery.
Dr. Vinan, this one is for you. We have seen, I mean, of course, we deal a lot of CKD in a given diabetic patient. We know it's an epidemic. So do you believe the spectrum of CKD or mineral bone disease is different in a diabetic kidney disease patient vis-a-vis a non-diabetic, or do you believe they just behave similarly?
So I think the data for that comes from studies that have been done in non-CKD patients who are diabetics. So diabetic non-CKD patients, you have the spectrum of bone disease in these patients that is more incidence of osteoporosis and more osteomalacia. So when we take that forward to the CKD population, we have problems in the diabetic subset, which is more metabolic acidosis as compared to a non-diabetic patient who has CKD. And metabolic acidosis itself is a very important contributor of a constant source of getting more bone loss. So most of these patients who are CKD diabetes will definitely have a more severe form of mineral bone disease as compared to their non-diabetic counterparts.
Very nice. I think that's very, very important and a clear message which Vinod has given. Vinod, another one. We were part of this trial. Jyotipriya talked about the role played by cinacalcet. We were part of that trial with edelcalcetide. We found that that was a very useful drug, intravenous during dialysis. And of course, we are talking about patients on dialysis already. Somehow the trial fizzled, and we don't have any more news about edelcalcetide. Do you have any? I mean, that's just for the sake of completeness of our discussion today. We have talked about cinacalcet. Would you want to give us any new knowledge about edelcalcetide? Where is it?
So, it's definitely not in our subcontinent right now, but sir, it is there, and it's a very novel drug. It's known to cause the activation of the calcium sensing receptor at a much higher threshold as compared to cinacalcet. I think the only drawback that this drug has is to ensure compliance of patients because it's an intravenous mode. And so you'll have better compliance only in patients who are on dialysis because they will come in dialysis room and you can give it to them. And but there is from the data that comes from the ESCOT trial, in which they try to use this drug upfront and compared it with cinacalcet upfront. They found that the incidence of hypocalcemia was a bit higher in the etylcalcetide group as compared to cinacalcet. But
Yeah.
the bulk of the data that comes for etylcalcetide comes from the EVOL trial, which was basically a cardiovascular trial in which they tried to show that it had good cardiovascular outcomes in patients, and they found that that's where the PTH was suppressed, and that's where the molecule was introduced.
No, the reason I asked was we were part of that trial and we found the drug to be very, very useful.
Yes.
So, and also just one more word about FGF23. You might recall we had given it as a part of a thesis to one of our DNB fellows at Gangaram Hospital, and the results were amazing with FGF23. There was a direct correlation with mortality. If you in your dialysis patient had an FGF23 levels of more than 2000, it was like a death warrant for that given patient. You would lose those patients within a period of span of about 6 months. So that's the importance of knowing about these new this thing. So we have come a long way. We have known who's the culprit and trying to target them. And in our endeavor, the kind of discussion we've had, trying to bring down the the phosphorus levels, trying to bring down the PTH levels. So many times we are on the other side. And of course, no discussion is going to be complete without a discussion on
Can I ask you
CAPD,
a question?
especially. No, sorry, sir. I was coming to that. Just a minute, please. I was saying no discussion can be complete without asking Professor Gupta for his comments on the role played by these overzealous therapies, especially in his patients on CAPD. So something which was referred to as low turnover bone disease or adynamic bone disease by Tarun. May we have some comments by Professor Gupta before we listen to what you were wanting to say, sir? Out of curiosity, your take on that concept of low turnover bone disease.
In patients on peritoneal dialysis, they have found that these patients most often have a low turnover disease or adynamic bone disease. And therefore, and this is something which is extremely important, that before you decide to start on, say, vitamin D analogs, etc., you must look at your PTH levels, because if your PTH levels are low, then I think the general suggestion is do not start with the vitamin D analog. So that you have to be careful about. The question that I was raising, Dinesh, was about this PTH assay, because a lot of discussion is about our PTH levels. And you have now PTH so widely available, you have so many different labs doing it. Early on, if I remember, when it was done in a very few selected, the collection of the sample was so extremely important. They would collect it in ice and then so that the results, but now you don't have that. So are the results that we get, are they correct? What is your take on it? I mean, do you accept the results that are coming in from various labs about the PTH levels?
Your point is absolutely well taken, sir. We've come a long way. It was a very tedious task to get the levels done, and we knew it as a 150 terminal, C terminal, and the N terminal. We were all the time talking about during our student days. But then, thankfully, we came across the intact PTH, and now it's much more easier, much more
So that has to be
reproducible.
collected in ice. I don't know
Yes.
whether that intact PTH can be done with just collecting the sample and keeping it like any other sample.
Exactly. The transport to the lab is crucial. That's one. The timing of collection is equally crucial, whether you are taking the sample early in the morning, fasting sample, and of course the rapid transport, preferably in those kind of ideal environments. So it is going to be a huge difference. But the problem is so many times the values are so high that we stop bothering about whether the collection was correct or not, because when you get a terribly high PTH, your focus is on getting the imaging done. So with that in mind, may I ask Tarun, what kind of imaging would you recommend to your patients, especially a patient has a very high PTH value? So would you advocate a parathyroid scan to all these patients? Would you believe an good ultrasound examination is good enough? What is your take on confirming the diagnosis?
So, sir, often with secondary hyperparathyroidism, even if you do ultrasound scans or you do, the nuclear scans, you may not actually pick up anything. So you might pick up that all four glands are hyperfunctional, or you can pick up even in tertiary cases that one gland becomes extra overfunctional as compared to others. But oftentimes you might not, if you do a routine ultrasound, you would not find you may or may not pick up the enlargement of the glands on ultrasound or even on nuclear scans. So essentially, you would actually rely on the serum, the blood levels of parathormone to make that diagnosis. You don't really have to do an imaging study to confirm. Um, Only if if the levels are very high and you're suspecting, tertiary hyperparathyroidism, or you are planning to do a surgical intervention, then probably that is the time then I'll go for an imaging study in such cases and try to confirm whether all the glands are hyperfunctional or what is going on.
Quite appropriate, and I think this is just to remind all those who have logged in today that when we are talking about secondary hyperparathyroidism, we are actually expecting all four glands to have undergone hyperplasia. But when we are talking about the tertiary one of the glands will probably become something like an adenoma, and all that you have to do is just remove it. And I also would like to remind that in the good olden times, the treatment used to be parathyroidectomy, the one gland, two glands, three glands, and probably a subtotal or almost all of them, and then have them placed in the forearm, because we know it's an endocrine and it'll keep on giving some parathyroid to the body. And I think this is very important. I'm really enjoying the kind of discussion, so much informative. Dr. Gulliver, this one is for you as well as Dr. Jyoti Priya. We are coming across a lot of iron-based preparation as well, which are claimed to be very effective phosphate binders. Are you using them? The question to both of you. Yeah.
So far, sir, I've not been using them very frequently, sir. I'm quite satisfied with the non-calcium based phosphate binders. And although even though we have a good population of dialysis, which we do, and patients, we have long surviving patients, we do have quite a bit of secondary hyperparathyroidism, but many of them are well controlled with the sevelamer and calcium and lanthanum. So far, iron-based calcium binders, phosphate binders, I have not been using very frequently. So my experience in that area is not very much.
Two questions. One of course is, are you using? And secondly, what is the science behind it? We are generally told that their efficacy to bind phosphorus is much more as compared to the other, be it calcium based or non-calcium based phosphate binders. That is one. And secondly, also I'd be curious to know whether there's any other pleiotropic effect, such as their effect on FGF23 also, believe sevelamer has it, and then we thought then maybe lanthanum also has an effect, a direct inhibitory effect on FGF23. Do you believe iron preparations, as is being claimed, also have a role to play there? Dr. Jyoti, that was in for you. Can you unmute yourself, please? Yeah. Dr. Jyoti Priya, you're on mute, please. Yeah. Yeah.
It's audible, right?
Yeah.
Regarding the iron preparation, I have started using sucralfaric oxyhydroxide, but not, it's like I'm not given enough to know the exact result, because one thing, its cost is high. So I have started trying in dialysis population, but as such, pill burden is high, as well as they have so much medications and the cost is high. So I have not had a sufficient experience to advocate it or not to advocate it. So regarding, as Gulliver sir rightly told, my experience with iron-based phosphate binders is not sufficient. Just started giving the sucralfaric oxyhydroxide. So I have to wait for the results to come, actually.
Professor Gupta sir, would you want to comment? Because there's certain talk about the role played by them, their efficacy, their strength in binding phosphorus, and then of course there are other effects of having an action on FGF23. It's not just sucralfaric alone, also ferric citrate, and then of course, I mean, we know that it's not going to increase the iron load. It's again a typical phosphate binder, which is typically binding the phosphorus rather than doing much to the iron stores. Yeah.
Yeah, I've used sucralfaric hydroxide in a few patients who have not responded very well to the maximum tolerated doses of sevelamer carbonate. And in the few patients that I have had reasonably good results using this in controlling the phosphate levels. So I think sucralfaric oxide, I have not used the other one, ferric citrate. So this one seems to be the point made by Dr. Jyotirpriya. The cost was high. I mean, that is, and the pill burden obviously goes up when you're using it in addition to sevelamer carbonate. So this is a new addition, and we need to wait for more experience before we make definite comments.
I think just the back end of the discussion today, and I think we should have some discussion around osteoporosis. Something very, very important. It's not as if our patients of CKD are not going to have osteoporosis. Obviously, it's going to compound our problems because now they have the age-related osteoporosis or some other factors-related osteoporosis, but at the same time, they also have an additional problem thrust upon them via CKD-MVD. There are quite a few drugs which cannot be given to our patients of CKD, especially the bisphosphonates. Tarun did talk about the role played by the denosumab and a few others. We know we can't afford to give them teriparatide. So we are left with very few choices. So may I ask each one who are here today, starting from maybe Vinod, you can take that up first. Your take on managing osteoporosis in a given patient of CKD-MVD, chronic kidney disease. Sorry.
Yes, sir. I think the most important thing is actually to look at the calcium levels of your patient when you're going to manage, and also the alkaline phosphatase. Am I visible, sir? Am I audible?
Yes, very much.
Yes. So that's one of the important things, and we use denosumab here in our patients, but we do find that there is a problem of severe hypocalcemia in some of the patients that we use denosumab. And a word of caution is also to look for underlying sepsis in these patients. So it can actually exacerbate sepsis. It seems to be a easy to use drug because it has to be given once in 6 months, but then there's a cost factor attached to it.
I think there's a caution you rightly pointed out. I mean, it's not free of its problems, and I think hypocalcemia again, as you rightly pointed out. So can we have Dr. Jyoti, your experience on and how to manage? I mean, Tarun, you are going to tell us. You said it's very difficult to manage osteoporosis, but then at the end of the day, you have to guide us as to how to best treat osteoporosis in a given patient of CKD. Jyoti, first to you.
Yes, sir. Sir, actually, in earlier stages, I have tried bisphosphonates, but in advanced stages, as Venant sir told, it's denosumab had come to rescue. But the problem is hypocalcemia, severe hypocalcemia I haven't encountered. And second thing is, we don't know what is the end point of the treatment. Every 6 months, I have to continue giving it. So the cost and the effect and the therapy, everything, and keep on continuing. And I have noticed rebound osteoporosis also once stopping the drug. So there is no end point. It's like continuing every 6 months. So that I had found a big issue. So to be honest, in my clinical practice, the first thing which I made sure to practice is to prevent fall risk, because treating osteoporosis and coming to an endpoint with it, it's very difficult, as sir had told. So what I made sure is to reduce the fall risk, what all we can do. Bone strengthening through pharmacological and non-pharmacological ways. So most of the time we have to resort to the non-pharmacological ways like muscle strengthening, gait training, physiotherapy. And apart from that, fall prevention, make the home atmosphere much more friendly for these patients, especially when they go to the toilet, having a grab bar, or avoid using non-slip mats and proper lighting of the house. And the second thing, like vision correction. So I gave focus to the fall risk management and reducing the fall risk strategy rather than the pharmacological method of correction of osteoporosis, because many times I have not found success in it.
Absolutely, very pertinent points. Thank you very much for sharing them, Dr. Jyoti Priya. Dr. Amit Gupta, sir, there was a talk, I mean, recombinant parathyroid hormone. The whole world, other than nephrologists, is talking about the role played by teriparatide. And we, poor nephrologists, are left to tend to ourselves without the availability of these effective tools to our patients. So there was some talk about the use of teriparatide even in patients of CKD. But then, are you using it? And that's number one. And otherwise, what is your plain strategy to treat your patients with osteoporosis, those who also have concomitant chronic kidney disease?
I think this is a very difficult area to treat. And I just wanted to know from you and the other panelists that are there now strict, are there any guidelines and recommendations of the use of denosumab as such with patients with advanced renal failure? I'm not sure if there are guide which suggest that you can use denosumab in our patients with renal failure, because
there's a caution, sir. There's a caution, and I think it's not advocated. And
it has not actually, there has been no recommendation the use of denosumab in patients with advanced renal failure. So I would sort of make a point that one has to be very careful, because denosumab has, as you mentioned, is associated with hypocalcemia and arrhythmias, and there have been reports of sudden deaths in some of these patients who are particularly on dialysis. So as of now, you can't tell people to use denosumab routinely in our patients with advanced failure.
So that leaves us with sheer frustration, and I'm going to come to you, Tarun. Before that, Dr. Gulliver, how do you treat osteoporosis in your patient? And I think we have to strictly follow what Jyoti Priya has said and try to take the help of non-pharmacological maneuvers, and I think bone strengthening. This is something which we advocate for all our patients, regardless, and especially true for our patients who are already on dialysis. So what is your strategy of treating osteoporosis?
So other than what Dr. Jyoti has said, she has very lucidly elucidated what should be done. I do not have an additional point to add. Our orthopedicians sometimes are very bold and they start giving denosumab and teriparatide with quite a relief in symptoms. But to be very frankly, sir, I do not have much experience in treating such patients.
No, that's the reason why I brought it up. You see, so many times you believe that mistakes are being performed, and that's why I'm spending some extra time on this. Very, very important, because nowadays it's become a fashion to order a DEXA scan, and typically you come across a T-score of less than 0.25, 2.5, and then obviously you have to offer something to the patients. Tarun, your final word. What will you offer to your patients with osteoporosis?
So, what the recommendations are, if you are not having features of CKD MBD. So if there's, even in the early stages, 1 to 3, if there is no hyperparathyroidism, the calcium and phosphate levels are in the normal range, I mean, you can treat as in the general population. Now, for stages for stage 3, if you have manifestations of CKD MVD, you first try, and there's osteoporosis, of course, you first try to treat the CKD MVD part. You try to, as per guidelines, you try to manage hyperphosphatemia, you try to manage the hyperparathyroidism, and that is what you do in the first stage. Up to a GFR of 30, you can use bisphosphonates in these patients. Now, when you're using either bisphosphonates or denosumab, they suppress the new bone formation. So you have to be actually careful that the PTH levels are not very low. So the concern is actually that you can precipitate adynamic bone disease if you are at all using them. So we do not have strong evidence, first of all, that they can be used safely. But if you have nothing else to offer and you're planning to give denosumab to a person with, say, CKD stage 4, then at least be cautious that the PTH levels are not low. Because if in that case, you can actually precipitate adynamic bone disease and cause more problems than solutions. So that is another word of caution which is there. And of course, we will have to have more evidence before we can use these drugs safely in these patients.
Well, I think I simply am enjoying this whole discussion, learning a lot in the bargain, and I certainly am not in a mood to say bye to all my.
Are you using denosumab? What is your take? I mean, you haven't told us how
Sir,
you.
I think, as I had said, out of sheer frustration, at times you find yourselves using denosumab. And we had a project even in our patients on dialysis. We had given this as a thesis project to one of our candidates just about a year ago. And the results were okay. I mean, I'm not saying in a small sample you are going to encounter too many side effects. But yes, from what we have learned, and again, there's a caution when it comes to the usage in our post-transplant patients as well. The safety data is lacking as of today in patients with more and more advanced CKD. So certainly, if even if we are compelled to use, let's say a given patient has already had some kind of fractures, is on dialysis, and the T-score is minus 3.53. Obviously, you are going to be wanting to do something for your given patient. Well, there are people who would believe that even a cautious usage of bisphosphonates, even as I said, of course, this is all after you have made sure that you have given them the right dose of calcium, the vitamin D, the magnesium, if at all. Magnesium used to be a big no, but I'm glad you brought it up today, because always we believed that magnesium is not for our patients of chronic kidney disease. Not any longer. Judicious use of magnesium also is warranted. So, but occasionally, answering your question, I do find myself using denosumab even in patients on dialysis, especially who actually deserve it. It should not be just at the drop of the hat that you're wanting to give them potent drugs like denosumab. And if you have started them, as Jyoti was saying, then there's no end point. I mean, obviously, you can't stop now. So basically, it's your prime responsibility to ensure that you monitor their calcium as best as you can.
Teriparatide?
I have not used, for the sheer simple reason that on one hand you have that report of parathyroid right there in front of you, and on top of that you're wanting to give them recombinant parathyroid hormone, becomes a little kind of controversy. But then, as I was referring to, there was some recent data which said, yeah, probably you can attempt going that path as well. But it's been a wonderful discussion. Frankly speaking, I've learned a lot. Thank you very much, all of you. Starting from Tarun with his wonderful presentation, to all the elite panelists. Thank you very much, Intas, for this wonderful opportunity. And I must congratulate them one more time for the kind of human service they are doing to the country by disseminating so much of knowledge on a regular basis, and yet without any personal interest. As you can see, there is no branding associated. They had agreed to be sponsoring the nitty-gritties of this webinars on a regular basis without really advertising any of their brands. So hats off to Intas, spearheaded by Mr. Amit Arora, who is ably assisted by Gaurav Khanna, Dr. Mithilesh, and today Dr. Vinod has done a wonderful job. Over to you, Dr. Vinod, for the concluding remarks.
Yeah, we would also like to thank each one of you, and particularly I learned a lot. And thank you, Dr. Tarun, once again for the excellent presentation. And of course, Dinesh for doing a great job in telling us about this particular entity, CKD-MBD, which is, I think, a very difficult one to treat. Thank you very much.
Thank you, Dr. Amit sir. So on behalf of Intas Pharmaceutical, I'd like to thank Dr. Dinesh Kullar sir for chairing this session. And of course, I would like to thank all the experts, starting with Dr. Tarun Mittal sir, Dr. Amit Gupta, Dr. Gulliver P sir, Dr. Vinant Bhargav sir, and Dr. Jyoti Priya madam for taking out time from their busy schedule and making this event a highly interactive and successful one. Last but not the least, I would like to thank all the audiences who have joined us this evening in such a huge number. Thank you, one and all. Good night, everyone.
Gaurav, do we have the number for today? Gaurav,
Yeah, sir. The live number is 1903, sir.
Oh, great.
Great.
So we are not able to hit the 2000. We tried our best, but it is
You
1903.
see,
Which I will share with the
for a change, it is a working day today. So out of compulsion, we had to choose Wednesday for the first time ever. But still, this number is very flattering. In fact, I would view it as the larger than our usual strength, because we know, and thank you very much for joining us today. I hope we lived up to your expectations, audience. So we'll keep on trying to contribute to this very noble cause of disseminating knowledge about CKD. Till then, stay tuned for our next edition, which is going to be on another very important and interesting aspect of chronic kidney disease. We will let you know the details of that given one very soon. Thank you very much, everyone, and have a good night ahead.
Thank you, sir.
Thank you, sir. Thank you. Good night, sir. Good night.
Thank you, sir. Thank you, Dr. Tarun, sir.
Thank you,
Vinay, sir. Thanks a lot for. Thank you, Gulveer, sir. Thanks a lot. Thank you, ma'am. Thank you for wonderful time. Thanks. Good night, ma'am. Good night, sir.